These drug reactions serve as a quick reference guide for high-yield side effects. It would be pointless for me to read these to you, so what I'm going to do is explain high-yield ones that you should never miss on your Step 1 exam and on real patients. I'm also going to include ones I've personally seen or be tested on and really go into those. Now, we'll start off with cardiovascular drugs and their important side effects. Drugs that cause coronary vasospasm include cocaine, sumatriptan, and ergoalkaloids. Now, cocaine inhibits the reuptake of catecholamines, including very potent alpha-1 agonists like norepinephrine. This can trigger vasospasm within the coronary arteries. Now, sumatriptan and ergoalkaloids are drugs used in the treatment of migraines. So let's draw a vessel here. And they have little receptors on them for 5-HT. Now this is serotonin. The pathophysiology behind migraines is complex, but one of the components is that these big, juicy cerebral and meningeal vessels are excessively dilated, causing pain. Now someone really smart discovered that blood vessels have these serotonin receptors, and when activated by serotonin or serotonin receptor agonists like sumatriptan and ergoalkaloids, when you hit these receptors, these will actually constrict. So we get constriction of these dilated cerebral and meningeal vessels. Now that's awesome for a migraine, but guess where it's not awesome? What if it's happening in the coronary artery? Now we have vasoconstriction within the coronary artery, potentially leading to coronary artery vasospasm, which will present as ST segment elevation. Now if a patient has been partying all night and comes in talking fast about his or her chest pain, think about cocaine. Alternatively, think about sumatriptan if it's an old lady with migraines who's now complaining of some sort of chest pain that's relatively new for her. Now, all of these drugs are important. Adenosine, niacin, and calcium channel blockers are all vasodilators. Dilating vessels in the dermis means that they get bigger and you can actually see more of blood flow, leading to cutaneous flushing. Vancomycin is famous for causing red man syndrome. This happens because vancomycin induces histamine release from basophils and mast cells. We usually give Benadryl and slow the rate of infusion to prevent red man syndrome from happening. Now don't worry about kinocandins. These are super rare drugs to actually be seen used, and they're more important side effects than cutaneous flushing. Now we get to anthracyclines. Anthracyclines such as doxorubicin and daunorubicin are chemo drugs that create DNA damage by not only intercalating into the DNA, but also reacting with iron to form reactive oxygen species via the Fenton reaction. Now, how do you think the chelating agent dexrazoxane helps prevent the risk of dilated cardiomyopathy when you're using doxo or daunorubicin? It's a chelator. So what's it do? It probably binds free iron within cardiac myocytes to decrease availability of free iron that might have a chance to react with doxo or daunorubicin and to create less reactive oxygen species. Torsades de Pointes is a polymorphic ventricular tachycardia, you can see on this rhythm strip, that can occur in patients with an abnormal phase 3 repolarization. All of these drugs listed here have something in common. They compete with potassium at the potassium channel so that there's less potassium efflux during phase 3 repolarization. Preventing this efflux can lead to prolongation of the QT interval because more time is required for potassium to leave the cell, and then more time is required to reach the resting membrane potential. These are a must-know for taking care of real patients and on test day. Always perform an ECG before giving a patient these drugs to see what the QT interval is. Classic ones always tested are haloperidol, ondansetron, macrolides, and tricyclic antidepressants. Why would glucocorticoid withdrawal cause adrenocortical insufficiency? Long-term use of exogenous consumption of glucocorticoids basically tells this entire feedback system to just take a day off, take a vacation. The classic drug described here is prednisone, a very potent glucocorticoid. It can directly inhibit the production of corticotropin-releasing hormone. So there's a decrease in the signaling molecule produced by the hypothalamus. Without any corticotropin-releasing hormone around, there is no one telling the anterior pituitary to produce ACTH. Low levels of ACTH mean that the adrenals will not be stimulated to function and can actually start to atrophy within just 7 days of use. The body senses a very strong glucocorticoid. It says, hey, prednisone's around. Why would it tell the adrenals to make a weaker glucocorticoid when naturally make cortisol? There's no reason to do that, right? Exactly, it won't. This is why you have to taper off your dose of prednisone. You have to do it over a period of days to allow the system to wake up. Remember though that low ACTH levels do not have an effect on mineralocorticoids because those are mostly controlled by the renin-angiotensin-aldosterone system. The mineralocorticoids include aldosterone and the ones down that pathway. Can you name 3 diseases in which patients would be taking a strong glucocorticoid like prednisone for a long period of time? First one's lupus, rheumatoid arthritis, and some sort of vasculitis. These are the kind of patients that you should be worried about adrenal cortical insufficiency from long-term use of prednisone. Why would tamoxifen or clomiphene potentially cause hot flashes as a side effect? Well, both antagonize estrogen receptors, right? That's the whole purpose of giving these to patients with a history of breast cancer. Well, antagonizing estrogen receptors is the same thing as having lower estrogen levels, which is what happens in females that are experiencing menopause when the estrogen is decreasing. Now let's talk about hyperglycemia. The calcineurin inhibitor tacrolimus and protease inhibitors can cause an increase in insulin resistance, while niacin and hydrochlorothiazide directly suppress the beta cells from releasing insulin within the pancreas. We can figure out how corticosteroids create hyperglycemia by thinking about the action of the natural corticosteroid in our body, cortisol. We know that cortisol stimulates gluconeogenesis and promotes insulin resistance. So it's a bad thing to have too much corticosteroids. High yield for step 1 exam. Now we move on to hypothyroidism. Here's a picture from your book, and it helps us understand how these drugs cause hypothyroidism. Lithium becomes highly concentrated within the thyroid, and through an unknown mechanism directly inhibits the release of T4 and T3 into the circulation. Now, amiodarone is a class 1, 2, 3, and 4 antiarrhythmic. Remember that. That's an important fact. It actually directly inhibits 5' deiodinase in the periphery. It prevents the peripheral conversion of T4 to the active T3. Now, the drug metabolites of sulfonamides are super reactive, and it's actually been reported that the metabolites of sulfamethoxazole can directly bind to thyroid peroxidase enzyme, and in this way it can lead to hypothyroidism. Here we go, a quick recall. A 4-month-old infant shows up in the emergency room with cyanosis. An arterial blood sample is chocolate colored. Oh yeah, buzzwords. What is the likely diagnosis and how would you proceed with treatment? Methemoglobinemia. Remember, the treatment is to reduce the ferric Fe3 plus iron of methemoglobin back into the normal Fe2 plus ferrous iron. To do that, you need electron donators such as methylene blue and vitamin C. Alright, let's start out with my personal favorite, diarrhea. There's a huge list of drugs, which we can see right here. All of these can cause diarrhea, but they're important because I guarantee you the first thing that will cause your patient to stop taking drugs is diarrhea. Singing on the toilet means I'm not taking that medication. Let's start off with erythromycin. It binds to motilin receptors in the gut, causing smooth muscle contraction, which can lead to an unpleasant diarrhea secondary to just a lot of peristalsis. Now, colchicine, it inhibits microtubule polymerization and limits the high regenerative capacity of the intestinal cells. What does that do? It means they die, and then they slough off into the lumen, and you get a weird diarrhea. Acarbose is an alpha-glucosidase inhibitor. This means that it inhibits this enzyme that's found in the intestinal brush border. So here's our brush border, and here's our lumen. This means that carbohydrates will not be absorbed, and they're going to stay in the lumen. They're going to pull water out and cause this weird type of osmotic diarrhea because of the osmotic effect of not being able to absorb carbohydrates. Pulls tons of water from the intestines into the lumen and gives your patient kind of an explosive diarrhea. Similarly, orlistat, which is a lipase inhibitor, is used by some people to lose weight. It can also cause an osmotic diarrhea. What do you think happens if you cannot break down lipids and they remain in the intestinal lumen? Well, again, here's your lumen. A bunch of fat is in here. It cannot go in, so water will be pulled out due to an osmotic effect. Now they get a weird, slippery, floating diarrhea. Pramlintide is a diabetes mellitus drug that works like the peptide amylin. This slows down gastric emptying. You can imagine how this can rebound and cause an osmotic diarrhea because ingested food is just going to be chilling in the gut. Selective serotonin reuptake inhibitors and metformin both cause diarrhea due to a similar reason. This is increased levels of serotonin, 5-hydroxytryptophan. As the name tells you, SSRIs obviously inhibit the reuptake of serotonin and therefore they lead to higher levels. But metformin does it a roundabout way. It actually stimulates the enterochromaffin cells to release more serotonin. But what does serotonin do in the gut? It stimulates peristalsis by activating the myenteric nervous system. Cholinesterase inhibitors trigger peristalsis by a different way, by preventing the breakdown of acetylcholine that make it more available. We know that acetylcholine causes increased intestinal smooth muscle activity. Patients that take long courses of antibiotics are particularly susceptible to C. diff colitis. These drugs stay in the GI tract for a long period of time. They stay in the lumen, they're not absorbed. They do this because we want them to, but sometimes they accidentally kill a lot of the microflora, the stuff that's good. If you kill all the bacteria in the gut, particularly resistant organisms or ones that are very good at surviving might just be left completely alone. All the nutrients are now available just for that organism. This means that a bug like C. diff can now have the GI tract all to itself. Recall that this is a gram-positive, anaerobic, spore-forming bacteria that's a tough guy. It's tough to get rid of. The diarrhea is due to the enterotoxin A that C. diff produces. It disrupts the intestinal epithelial cell organization of actin filaments. So when these cells are touching each other with actin, like this on the brush border, if these tight junctions here are disrupted, there is going to be damage to the ability of these cells to prevent water to leak into the lumen. And that is exactly how fluid leaks out into the gut lumen, causing a very profuse, watery diarrhea that C. diff patients tend to have. They'll have 10 or more bowel movements every 24 hours. Now, how do you treat this? You give by mouth PO metronidazole. It's the first option, followed by PO vancomycin if the patient cannot tolerate metronidazole. Other high-yield drugs are ones that can kill hepatocytes and potentially cause full-blown hepatic necrosis. Now, halothane is an inhaled anesthetic used right before surgery, pre-op, and it helps for the induction of other anesthesia. Hepatocytes break it down by forming a dangerously highly electronegative free radical metabolite, which is trifluoroacetic acid. You don't have to know the name of it, but it helps understanding why this is so bad. This electron scavenger literally go to hepatocytes and pull off phospholipids from a hepatocyte's membrane, leading to lipid peroxidation and hepatocyte injury. Wait, didn't we recently talk about another metabolite formed by hepatocytes that can also do this? We sure did. It's called NAPQI. It is the acetaminophen metabolite. It depletes glutathione in the reduced form, and glutathione is depleted. Hepatocytes cannot protect themselves from naturally occurring reactive oxygen and reactive nitrogen species. In addition to NAPQI going around and causing damage, this decrease in ability of cells to defend themselves against oxidative stress is why acetaminophen overdose can lead to hepatic necrosis. Now watch out for the hipster or the weirdo eating wild mushrooms that accidentally comes across a toxic species of mushrooms called Amanita phalloides. These have very potent amatoxins and phallotoxins. These toxins directly inhibit the hepatic RNA polymerase. If you can't use your RNA polymerase, you cannot do anything that is involved with protein production. Valproic acid, extremely high yield. We use this all the time. It'll always be on your exams. Acid is metabolized mainly by the liver, and sometimes patients can break it down into very dangerous oxidative metabolites that can similarly destroy hepatocytes by the same mechanisms that we talked about with halothane and the metabolite of acetaminophen. This is why patients on valproic acid always have their LFTs or liver enzymes checked regularly. Who are the patients taking valproic acid? Epileptic patients, bipolar patients. Drugs like rifampin, isoniazid, pyrazinamide, statins, and fibrates can all cause hepatitis. The mechanism behind hepatocyte injury appears to be a hypersensitivity-like reaction. A hypersensitivity reaction in the sense that either this drug or one of its metabolites can bind to hepatocyte proteins, forming a protein complex and drug complex that the immune system just does not like and will soon start to form antibodies or a cell-mediated reaction against. Now let's go back and talk about erythromycin some more. This is a high yield one. People stopped even giving this because of all the side effects. You got to know why not to give drugs. It enters the enterohepatic circulation and is excreted into the bile. In some individuals, the immune system will see this metabolized form of erythromycin that's circulating in the bile and start attacking wherever the drug is found. Unfortunately, in this situation, it happens to be hepatocytes and the biliary tree, right, where bile is found. The destruction of hepatocytes leads to elevation of liver enzymes, and the inflammation within hepatocytes and the biliary tree can also lead to jaundice. Now, 70% of acute pancreatitis is due to gallstones and alcohol use, while only 1% of pancreatitis is due to drug side effects, not including alcohol. So we look at this list right here. Your pancreatitis questions will be related to stones and ethanol. It is much more important to remember the mechanism of high-yield drugs such as valproic acid and azathioprine for step 1 instead of this 1% chance of the side effect. It's not worth your time. Pill-induced esophagitis is something that you see in a lot of elderly people. This is due to prolonged contact between the drug and the esophageal mucosa. So drug, too much time hanging out the mucosa's house. These vignettes must include tips onto why or what the drug the patient is taking is sitting in their throat for so long. Basically, they have to give you a tip off of which drug was used, and they have to give you some clues that the patient has problems with swallowing. These vignettes usually describe a patient with a history of difficulty or painful swallowing, which we call odynophagia or dysphagia. They're going to be presenting with an acid-like reflux or GERD-like set of symptoms, maybe retrosternal pain after swallowing, after starting a new medication. There are a few classic vignettes, such as an old lady with osteoporosis, recently started on a bisphosphonate like alendronate. Now, 50% of pill-induced esophagitis is due to tetracyclines, particularly doxycycline. This is because it comes in a huge capsule and literally gets stuck in the esophagus. It's like swallowing a horse pill. Not many doctors give potassium chloride anymore, so don't worry about this.